So we have about 20 minutes to have the three groups report back. So what I wanted to do was have each group take about 5 minutes to present their results, and then we'll take about 5 minutes for questions and answers. So the first group that we're going to have present, Marianne and I thought it might be good to start with more the concrete and then move out towards the big picture. So we're going to start with parenting in primary care, as that directly follows on our discussions this morning, and then move to research and then move to next steps for the forum. So Costella, do you want to start and share some of your results?
I am special. Okay, good morning. I'm Costella Green from SAMHSA, and our work group, we focused on parenting. Really quick, I'm just going to run through what our big, what we came away with. Dr. Hawkins did a presentation on what our thoughts were from the strategic planning meeting back in February. And we presented our findings from February and some of our thoughts and ideals that we've been working on collaboratively, but we wanted to seek input from our group. So what we did rather quickly, we had a lot of people. I don't think we knew we'd have that many people, but people were interested, so we were happy. And the big things that we took away from just doing what we call our big picture of parenting and primary care, I'm going to say these top three things, and then if Dr. Hawkins has anything else, please add on. Our big message was to talk about universal, more so than selective. Not that we left out screening, because we still talked about screening, but it was very important that we talked about universal. I like that we talked about reframing our message. A lot of people, we heard that over a couple times, as well as meeting people where they are. That was very important. We talked about minority communities, including minority researchers, and to make sure that we had a collective voice across the country if we're going to be impacting the nation, because that's really what our work is about. Those were, wait, I have a couple more, wait. We talked about faith-based. I'm so sorry. We had, it was great discussion. I'm just sorry. It was like very rich. And I have 5 minutes. And we talked about
you and David have 5 minutes together.
I know, so that's scary. We talked about the internet. Again, everyone doesn't have the internet, so we have to be thinking about different avenues to reach families. We did talk about that as well. We had a doctor who was very, very helpful, because he told us that he only has about 18 minutes, if I'm correct, and he said they're task-oriented, so it's very hard when you include all the other. So I remember Karima talked about the community and how we would include community to help with the resources to help us get some of the work we want to get done in primary care with parenting. Hurry up, Dr. Hawkins.
So just a couple of drill deeper points. We've got to move to family medicine as well as pediatrics and other forms of primary care. We can't just make it for pediatrics, or we're going to miss a big proportion of the people who we need. People had brilliant ideas about how to change norms so that there is demand or pull. People want these kinds of things, and suggestions about do this for your child's brain development. Trying to find ways that will hook people in, and trying to find ways to use the media. Large corporations that are already providing Pampers, Procter & Gamble, I think Bob Amer mentioned Procter & Gamble, is already providing a lot of Pampers to people, but they also care about children's health, and they could, and we see every evening, if you watch the evening news, ask your doctor about this, ask your doctor about this. Why don't we have large corporations saying, ask your doctor about parenting? Ask your doctor about the parenting program available at the clinic, et cetera. So creating demand, and I think it may be actually easier to change norms and create demand on the part of parents than maybe on the part of practitioners. Creating the demand on the part of the practitioners to say, yes, I want to do this in my practice or in our practice, in our clinic, et cetera, may be a bigger challenge. And so we're going to really need input and help from people to think about that. And I guess this whole reframing of help from prevention to health promotion to brain development to positive development for young people as a way of overcoming the stigma that's often associated with parenting involvement, I think was an important point that people made. So those are some thoughts for you.
Wow, that was under 5 minutes. I'm very impressed.
Oh, well, we have more.
Hendricks, do you want to give a summary of the research and service group's discussion?
Sure, it was research and service, and I thought we had a really lively discussion. We had representatives in that group from service providers and policymakers, researchers. We had people from foundations. We had people who represented practitioners in here. It was very clear we didn't have one group in there, and that is parents and other people from the community. And that was almost the first statement we had, was the middle statement and the end statement. And I think there was a message there that we really don't have the kind of broad grouping in here. We recognize that that there are viable models that are already been used before for doing service and research together. I never get this exactly right, so I never pronounce it quite right, but M.P.H is one of those programs in here that HRSA has been involved in Agency for Children, Youth and Families. NIDA has done a number of programs in here to link up with SAMHSA. I think that's a great model for working together and collaboratively. We talked a little bit about the words research and evaluation. It's easy to reify those as distinct and quite different from one another, but we basically decided we really needed both of those together and complement, and that's a big important piece we had. We thought about several different places that are really useful opportunities for building fairly rapidly the cycle of decision making that Congress has, of providing funds, for example, doesn't always give you a lot of time to be able to do some planning in here. Sometimes the money is just there all of a sudden and it needs to be spent on services without the backbone of really developing the research agenda along with that. So we started sort of quickly laying out what are the kinds of opportunities. It might be a year or two potential for building in a good research component on programs that got rolled out the very beginning of the first year, but then use some sort of a rollout design in here. We also thought that it was good to use the kind of language that John Lanswick used in here about using hybrid kinds of designs to integrate in implementation at the very beginning in here. We know that there's a lot of opportunities in here. The CMS and CMMI world is doing lots of very rapid rollouts. They are getting into behavioral health for children. Unlike they had been before. There's now really good opportunities in here. And then we talked about what is the mechanism in here. That's where we sort of ended the conversation about the role that the IOM could be used as a convener of pulling together groups of people in here that could do some planning in advance. And we thought that the IOM could be in a unique position in trying to build people and build that partnership together in doing more strategic planning. I know that the forum is not doing recommendations, but we can certainly call up people and get people to come. So anybody else have, there's a group in here want to add in the last minute?
Great, thank you. Bill, do you want to share with us about the group that was discussing next steps for the forum and collaborations?
Right, I want to do two things, and I got Marianne's permission to do this, which is first to comment on an incredible resource that has appeared. Tony Biglan's book, The Nurture Effect. Tony was on the IOM committee with Hendricks and me and has really written a marvelous book. Dennis Embry says, please read this book. If you want to improve the now, better the future, read this book and apply the nurture effect at home, at work, or at school and in your community. And I said, this marvelous book integrates the most compelling scientific knowledge about how we can improve the lives of the citizens of this country with a bold call to action. So I recommend it to all of you. I do it deliberately. This is a terrific book. So the issues that we talked about could both be featured in forums and could inform our discussion in other ways. The first and one of the most compelling is, how do we reach the people that we're not reaching? An example was, if you're doing a program on maternal and child health or infant mortality, who are the people that we're not reaching, who aren't coming in, who are not there? And I think that relates to the larger questions of population health and implementation dissemination. So I think that's a very important focus. The second issue is how to effectively engage schools and education in this whole enterprise. We had lots of discussion about that throughout the meeting this time, but really, who's done that well? What are the barriers? To really take that one on, I think, is important. The third issue was the issue of framing. And it was interesting, one of our members pointed out that there was a moment yesterday in which there was real disagreement about the data about Head Start. And, you know, those kinds of disagreements don't really help us very much in framing things for policymakers. We need to be clear about what we have to say. We need to be succinct. And I think the whole question of how we frame behavioral health intervention, behavioral health prevention is really important, and we need to rethink that. Certainly, we talked about the need for cost effectiveness data and a real focus on that, but also to look at the cost effectiveness in some of the new innovative models, such as health homes under Medicaid, and that probably there's a piece of work to be done there. Another large issue, very much like the first issue of who are we not reaching, is the issue of partnerships. What contributes to really good partnerships? How do they emerge? How do partnerships with families emerge? How do parent-to-parent programs work? But much larger, the presentations this morning are really about partnerships between behavioral health providers and primary care or family medicine. What contributes to those? What kinds of things make those happen? And similarly, larger community coalitions. We've all talked about, and we emphasized, that we need to really take very seriously reframing the workforce question and think about how we develop the workforce that can deliver the kinds of preventions and treatments we need, how we take things to scale. And finally, I think that, at least to me, as I listened to the talks yesterday, the issue of economic disparity, health disparity, wealth inequality runs throughout all of these conversations. It's part of the ACEs. It drives a lot of the disparities in mental health. It drives a lot of the disparities in physical health. And I think we need to take that on and look at it relative to behavioral health treatment and behavioral health intervention. So I think I'm in time.
Perfect. You can have 30 more seconds.
In our group that I think is one that we really have to wrestle with. And that is, as we think about this, to what extent should we be thinking about these services in the community? Felicia Bowen really, explains to us how she goes out to the early childhood centers, and that provides an opportunity at pickup time to have some ongoing child care provided at the same time that you could do an hour with the parents in a small group kind of setting in the place that their kids are already there and you're going out into the community. We heard several examples of that. And at the same time, we hear from Tom Boat saying, but wouldn't it be wonderful if it could be one-stop shopping in your primary care clinic? And those are both, you can make compelling arguments on both sides. And what I think it really suggests is we need research to answer the question of where's the uptake best? Do you get better uptake? Do you get more people in different kinds of communities? What's the uptake and what's the effectiveness? Does it differ in those kinds of settings? Because those are fundamental questions as we move ahead that I think require some additional research. So.
Great. So I'd like to open it up to the audience to either make comments in response to the three presenters who shared back from the groups, or to elaborate on something that came up in your group. I think you're up.
I didn't think I'd be the first person. I just want to suggest one thing that hasn't been discussed and I think might be useful. If you look at any psychological behavioral health problem that we're trying to deal with from a public health perspective, you're going to be interested in the incidence and prevalence of that problem. But I think there's also a sense in which it would be useful for us to begin to focus on the prevalence of families that are sufficiently nurturing. Tom DeShawn took an 8-item scale, which he was getting middle school kids to fill out. And then he was able to do direct observation in the families and validate those 8 items. So what I'm saying is that it may be possible through surveys to get estimates of the prevalence of families that are not engaged in harsh coercive discipline. I mean, there's a lot of research that would need to be done to get to that point. But I think that if we start to assess the prevalence of nurturing families by whatever standard you identify, that begins to focus everyone's attention on that and bring together all of the parties that are concerned about trying to affect that. And you could do that at the community level, as David and I described in a monograph we wrote some years ago, or you could do it at the national level or at the state level.
And there's something about that that's strength-based also. It's shooting for what we're trying to get at as opposed to identifying who's got a deficit. Yeah. Thanks.
Nathaniel, Councilman Health America. I just wanted to bring up a workshop direction idea, which is a lot of the previous workshops have looked at sort of funding and scaling up in a programmatic approach. And I was thinking maybe you could look at non-programmatic approaches where you sort of disaggregate some of the programs into their specific behavior changes and then look at behavioral economics models or law and social norms models to try to affect the change that's desirable without sort of a top-down training programmatic approach.
Hendricks, do you want to reply to that from the Research and Service Design Group's perspective?
I don't know if I have a great answer to that right now. I think that those are intriguing. We don't use knowledge from behavioral economics much at all in this field. I think this is a big untapped area that really would be able to help us. I would add in there maybe something about the complement of trying to use technology to be able to support the major roles that we have that we are struggling with, of trying to get individuals, even identify individuals in the community as opposed to those who come to the clinic, for example. The second and we've talked about all of these same problems. I don't think I need to say them again, but I think maybe the complement of these things. I do think one of the things that we need to really think about, though, is to think about this as a system level issue. I think what we've gotten to is the opposite side of this is we've always talked about, does this particular intervention work? For example, does screening work? And no one in the right mind would say screening would ever work without a backup support for that. There's zero chance of that working without that together. And so what we've been doing is talking about smaller pieces that don't make sense by themselves, but are only in complement to a whole system. And we have to start talking at a system level.
Alicia.
I just wanted to say something in terms of dissemination. We know that we have great science, but we kind of just keep preaching to the choir. We publish in scientific journals, we speak at conferences with other scientists, and we have to find a way to push this down to the lay people, the end user. And yes, there's parent magazines that are in the waiting rooms and stuff, but why not? Just a thought that I had was cosmopolitan, how do you frame this? Put in a Cosmo. Well, why do you want to learn about parenting? Well, improve your sex life by having your kids behave better or go to sleep or whatever, So it doesn't sound so crazy, but that people read those. And then in there, people will probably go to their provider and say, oh my God, my kid's up until 10 o'clock at night and then I'm too tired. And I hear there's these great, programs and whatnot, and I want to talk to you about this. So that might be something. Get on Oprah Winfrey, or how do we get Dr. Phil, to, do some of these things. So maybe, again, thinking outside of the box and looking at some of, there's the men's magazines, Sports Illustrated. I don't know some of the other guy magazines that are out there, but, again, when you have sex in there, it's like, oh, 10 ways to improve your sex life, be a better parent, or whatever, set limits with your kids. So something to think about, but there's different ways to frame our messages to
Right.
get other people to read it and to understand it. And we can wish it down so they can understand it, but putting those things out there and people will go and ask, right?
Actually, I want to pick up on that because I think it ties into a theme that came up in general here, which is how do we change norms? How do we message? Who are the stakeholders who are not at the table? How can we use the benefit of being an IOM-sponsored forum to move change? And I just want to, we've got about 1 minute. Does anyone on the panel want to talk about any of those within the context of their group?
Just say briefly, Lori Stark had some great suggestions about thinking about how to use behavioral economics. And she says, just look at what people look up on the internet. And Google tracks what people, and she says, look at the most frequently requested topics. And that gives you an idea of what's normative. Just people want to do what's normative. And so if we recast what we're talking about in terms of this parenting, in terms, how, people are asking about this, people want to know about this, people care about this, you really begin to change interest. You create demand or pull for it, and that's the same thing I think Felicia's trying to do. People are talking about if the big corporations that advertise all their pharmaceuticals on the nightly news we're ending their thing with ask your doctor about parenting, it would be one of those things where you get a change in behavior at the normative level. Oh, that's a normal thing that people do. People want to know about. I'm going to ask my doctor about that. And if the doctor had an answer, be good.
I would agree with that. I would also say that, the Frameworks Institute has been really helpful to a number of groups in framing the message about early childhood and the importance of that. And I think we need to think about how we engage people who really know how to influence media and how to frame things in ways that are very friendly to the end user.
Great. I want to thank all of our panel members for reporting back for their groups, and we're going to move to another panel.